I'm Dr. Randall Oyer, President of the Association of Community Cancer Centers. Thank you for joining us today for our presentation of the 2020 ACCC Annual Achievement Award. This award was established by ACCC in 1980 to recognize distinguished individuals or organizations that reflect the values of community cancer care through outstanding contributions to the field. It is my distinct honor to present this year's award to Dr. Lawrence Shulman. Dr. Shulman is Professor of Medicine at the Perelman School of Medicine, University of Pennsylvania, where he is Deputy Director for Clinical Services of the Abramson Cancer Center. In this capacity, Dr. Shulman leads the Cancer Quality Program and Strategic Development of Cancer Services across the University of Pennsylvania Health System's 6 hospitals and affiliated practices, including the Penn program where I work in Lancaster, Pennsylvania. And I should add that Dr. Shulman has been a great mentor and support to me and my cancer program. Dr. Shulman is also director of Penn's Center for Global Cancer Medicine. Dr. Shulman is internationally known as a breast medical oncologist, an oncology practice thought leader, and as a mentor. Over the decades and wherever he has worked, Dr. Shulman has kept an open door to students, trainees, and others from around the world who regularly seek his wise and generous counsel. Dr. Shulman's work in low-resourced areas throughout the United States and overseas is particularly notable. This includes the promotion of early detection and helping to establish and maintain cancer treatment programs overseas. Dr. Shulman has led and implemented remarkably successful cancer programs in Rwanda, Haiti, and Botswana. One example, Dr. Shulman and his colleagues trained hundreds of clinicians in breast health care who now provide breast screening to thousands of patients in 4 districts of Rwanda. Dr. Shulman's team efforts have led to significant improvement in patient outcomes in an area where women previously had no hope. Dr. Shulman's leadership work includes the National Cancer Policy Forum of the National Academies, as well as chairmanship of the Commission on Cancer, the American Society of Clinical Oncology's Quality Care Committee, and the Commission on Cancer's Quality Integration Committee. One of Dr. Shulman's most extraordinary and remarkable abilities is his ability to take in, synthesize, analyze, and understand a remarkable amount of information and to recognize and effectively act on what is truly important. With so much to be done around the world, Dr. Shulman is often asked what should be done. And in his unique way, Dr. Shulman has influenced cancer care across the US and across the world. Thank you, Dr. Shulman, for accepting the 2020 ACCC Annual Achievement Award.
Hello, everyone. I wanted to thank Dr. Oyer for that very generous introduction, and moreover, and obviously more so, thank him and ACCC for bestowing on me the 2020 Annual Achievement Award. I'm truly humbled by this for many, many reasons, and I'll talk a little bit about that in the next few minutes. You already know who I am, so I'm not going to spend any time on this slide. But my name is Larry Shulman, and again, thank you so much for this award. I wanted to thank ACCC for a couple of things aside from the recognition and the award. I wanted to thank you all for what you do for the quality of cancer care in our patients, for our patients in the US. And not only for raising the level of care, but for your advocacy for our patients and for your advocacy for our clinicians who support our patients and take care of them. And these are no small feats. Your impact in this area is really considerable. Now, cancer care in the US, you know all of this, is mostly delivered at community practices. About 60 to 70% of our cancer patients in the US will receive their care in hospitals close to their home. And that's part of their integrated healthcare environment. It's part of their primary care physician environment, their specialists such as cardiologists. And the care is given by clinicians they know, often they've known for many years, and who they trust, and their care can truly be integrated. And we need to support that. But cancer care delivery is ever more challenged. There are rapid changes in treatment paradigms and diagnostic paradigms. And that's good news because, in fact, our patients are living longer, doing better, but keeping up with it all is a huge challenge. There are increasing pressures from the regulatory and payer groups, and we need to keep abreast of those and satisfy the demands they make on us. There are increased administrative burdens like pre-authorization and others. There's a growing shortage of oncology professionals, and I'll talk a little bit about that later on. And we all know about the increasing economic pressures, not only in our own practices, but with our patients as well, particularly through this COVID pandemic. I wanted to spend a minute talking about this article, which Atul Gawande wrote in 2004, originally published in the New Yorker and later in one of his books, called The Bell Curve. And I think if you haven't read this, it's worth finding it and reading it. It's not about cancer, it's about cystic fibrosis, but he goes through the factors that separate high quality cystic fibrosis care from just average cystic fibrosis care, why those differences exist, and what effects the differences have on the likelihood of a patient survival. And I think there are many lessons in this article. When I think about the article, I think that medical outcomes are the sum of many, many little details. And we all know that. We all sense it. Sometimes we don't think about all those details, but they really all matter. And I think systems are critical and people are critical. You can have outstanding physicians, oncologists, clinicians, nurses, but if the systems that support their care and support their patients are poor, their care will never be excellent. On the other hand, you can have excellent systems, and if the people who are providing the care are not excellent, the care will not be excellent as well. So you really need both of those to provide the kind of care we'd all like to provide. And I think it's important to remember that when thinking about providing that care, we need to have the data that tells us how we're doing. We need to be able to ask the right questions. And if you don't ask the right questions, you won't understand your performance. And one of the things that I tell my own colleagues is without data, you're just another person with an opinion. And even some of my best friends and best oncology colleagues, sometimes say, well, I know we're doing great here or great there, but they really don't have the data to show how we are doing. And I think that's something that we need to do better at. There are also, as we know, incredible inequities in cancer care outcomes in the US. And in my role as the chair of Commission on Cancer for the last 4 years, I've had the opportunity to explore the National Cancer Database and show that survival outcomes for our patients sometimes are in fact more regulated by their zip code than their genetic code, because there are differences in our population. Insurance coverage or lack thereof, and that's become a bigger problem with the COVID pandemic, as has poverty, health literacy, transportation challenges, rurality, and lack of access to high quality diagnostics and care all influence how the patients in this country do in fighting their cancers. So we've made incredible advances in cancer care. The mortality for cancer has gone down significantly over the last couple of years, but these inequities do exist in the US, as I've mentioned, and that leads to countless what we would consider to be preventable deaths. And some people have estimated that in the hundreds of thousands or even millions in the US. But larger inequities in care and outcomes exist in the majority of the world outside of the US. And with better control of HIV and TB and malaria over the last several decades, cancer has become one of the leading health problems in the world, in Africa and Asia and elsewhere. And often these places have weak healthcare infrastructures. They have a lack of diagnostics and treatment and skilled physicians. And this leads again to millions and millions of preventable deaths every year. The wonderful advances that we've made in this country and in other countries in cancer diagnostic and therapies are unavailable to so many in the world. Now, I did mention about the workforce, and I think everybody who practices oncology knows this. These two articles are articles we published based on a workshop from the National Cancer Policy Forum, The upper one is developing and sustaining an effective and resilient oncology care force, opportunities for action. And you'll notice that one of the authors is Dr. Oyer. And the second is a viewpoint, the future of cancer care in the United States, overcoming workforce capacity limitations, that we published in JAMA Oncology. Both of these were published this year, and both of them point to the fact that in spite of all the things that I've told you about the stresses of increased complexity of care and many other things, that the number of oncologists is not keeping pace with the number of cancer patients. And we need to be more innovative in how we provide care and more efficient. So how can we do better? We can develop systems of care in the US that better support our clinicians and improve our patients' outcomes. And it has to be contextually. The answers might be different in Philadelphia, where I work, than in eastern rural Alabama or eastern Kentucky. And we need to attack the problems. We need to identify the gaps in care and attack those. And we need to develop systems of care in resource-constrained settings in the US and elsewhere, like in Africa, to better support our clinicians as well. So I wanted to switch now to talk about another part of my work, and that is work that I've done in places like Rwanda, in Botswana, and Haiti. Much of it's been with Dr. Paul Farmer and his organization, Partners in Health. This is our cancer hospital in Butaro, northern rural Rwanda. It's a beautiful location. It's a relatively new hospital that we opened in 2011. And we've learned a lot trying to provide cancer care there. And I will tell you, as I've met with my colleagues from around the country, many of the lessons are applicable here in the US as well. I often tell my colleagues and my students that the challenge in global cancer medicine is not knowing what to give. It's not knowing what the best treatment is for a patient with hormone receptor positive breast cancer, but it's trying to figure out how to safely and effectively and sustainably deliver high quality and reliable care in the context of weak healthcare infrastructure, environmental factors, weak human capacity, and patient poverty and water and food insecurity and transportation challenges. And these are huge problems in places like Rwanda, but again, in some places in the US as well. So this is a slide that Paul Farmer gave me, which really helps to crystallize how we approach our care in places like Rwanda. We go, we make house calls, we build health systems, and we stay. And in fact, in all the places I've gone with Paul, we've never left any of them. We're there for the long haul. We think of the care that we provide in the 5 S's. We need good staff, we need good stuff, maybe chemotherapy and other cancer care supplies. We need space to deliver that care. As I mentioned, we need systems to support the care. And particularly in these areas, and again, in many areas in the US, we need social support. And we need to be there on an ongoing basis. So cancer care in resource-constrained settings is controversial. These are real quotes from very high-level healthcare policymakers, that cancer care is too complex, can't be done in these locations, and we should only do prevention, and 1/3 of the cancers are preventable from smoking, cessation, and other factors. And this is a debate that I participated in at the World Cancer Congress in Paris in November of 2016, where I debated in favor of providing cancer care in places like Rwanda, and Karen Canfell on the right argued against it, though I will tell you she really believes that we should do it, but she was assigned to the other side of the argument. And before the debate, only 25% of the audience thought we should provide cancer care in places like Rwanda. After the debate, I moved 20% so that we were at 45%, but still in the minority. And I showed this slide during the debate, which is from our pediatric cancer ward in Rwanda. And I told them that none of these kids have a preventable cancer, that in fact, none of them are due to smoking or obesity or some of the other things that we worry about in this country. And though they look like a happy bunch of kids ready to go on a picnic, if you look carefully, you can see that each one of them has an IV in their arms, and each one of them was receiving chemotherapy that day. If these kids lived in Philadelphia and went to Children's Hospital, their cure rate would be about 85%. And how can we turn our backs on kids like this? At that same conference, we discussed what partnerships between a U.S. cancer center and a place like the Rwandan Cancer Center should be. That's my colleague, Dr. Cyprian, on the right. And at the end of it, he said, the only measure of success is patient survival. We need to figure out ways to deliver care and prove that the care is safe and effective and that our patients survive. Our vision for cancer care in Rwanda is really the same as it is in the US, or should be the same, and I'm not sure we always live up to that. Patients should expect accessible, high-quality cancer care for treatable and preventable cancers. Care should be affordable. Poverty should not be a barrier to care. For many in this world, it will mean that the care must be free. And that's for many of our patients in Rwanda, and we do provide free care, but it also applies to many patients in the US. And we have to develop and strengthen in-country capacity for all aspects of care, for physicians, for nurses, for laboratory technicians, and so on. So when I first went to Rwanda in 2011, the number of oncologists in the country was 0. The number of pathology labs in the country was 2. Each of them operated for about 2 to 3 months a year because of machine downtime, reagent stockouts, and other problems. The number of cancer programs in the country was 0. There was one private hospital that treated a few patients, but it wasn't really a program. The number of radiation units in the country was 0. And the cancer mortality in the country was nearly 100%. And if you talk to the people in the country, they'd say, well, we knew in 2011, if you had cancer, you went home and you died. Nobody survived. But we decided, along with the Ministry of Health, to build a cancer center, and that opened in July of 2012. Former President Bill Clinton was the godfather, if you will, of our cancer center. He helped to raise the funds for it, and he worked with the Rwandan government. Paul Farmer is on the right, and to the right of me is Agnes Binawahu, who was at that time the Minister of Health, and Chelsea Clinton, President Clinton's daughter. We, from the very beginning, felt that implementation science for global oncology was an imperative. We needed to evaluate the safety and the efficacy of cancer care delivery, and we published this article going over the details and the reasons for this in JCO in 2015. But I would also say that this is true for the US, and we don't, as often as we should, evaluate what the outcomes of our care are and how our patients are doing. So how do we do that? And how do we get from this? This is another picture. This is right outside of our pediatric cancer ward with some of our patients. And the little boy on the left, Fabrice, was 4 years old at the time that we took this picture and was diagnosed with Wilms tumor and nephroblastoma. And he was actually on the wards when President Clinton dedicated the cancer center, and he got to meet President Clinton, as did his mom. And that's him with his mom on the left at a time shortly after his diagnosis and with relatively inexpensive chemotherapy and surgery. Fabrice on the right is the little boy on the right, now 8 years old, 4.5 years after diagnosis, disease-free and a thriving, adorable little boy. So we didn't take it for granted that we were doing okay. We collected the data. This is really a form of implementation science. We followed International Society for Pediatric Oncology guidelines in the treatment of our patients and published this in 2016. And we'll republish updates on this shortly. It got waylaid a little bit by the pandemic. But almost every one of our papers has a flowchart like this, which tells you exactly what happened to all of the patients who came to our cancer center. Here, 4 of them died even before treatment was initiated because their cancer was so far progressed, and so on, all the way down the line. How many were lost to follow up, and so on. and what the ultimate results were. And when we first published this, 59% of our children were disease-free and doing well. That's much better than the 0% when we started. But if these children lived in Philadelphia, that would probably be 85%. So we've gotten part of the way there. We identified some gaps, and hopefully our results will continue to improve. There are many barriers to providing care, and some of it is the affordability of cancer drugs. And all of you know how expensive our cancer drugs are, particularly some of the very effective newer agents. And frankly, we can't afford them. I buy all the chemotherapy for our cancer center with philanthropic dollars, and I can only buy what I can afford. And so our patients there do not have access to life-saving drugs such as trastuzumab or rituximab, though we're hoping to change that. But there is another story in this regard, and this is a young man who was diagnosed in 2012 with chronic myeloid leukemia with a white count in excess of 300,000. And we were able to make the diagnosis of CML with the BCR-ABL assay. And we were able to give him free imatinib for life, free of charge from the Max Foundation, which was partnering with Novartis that made imatinib. And he is in fact doing great. He's in remission now many years later. He could never have afforded this medication without the Max Foundation and the Novartis partnership. And Pat Garcia-Gonzalez, who's the CEO of the Max Foundation, and myself and some of our colleagues wrote this viewpoint commentary that was published in ASCO's Journal of Global Oncology, the role of humanitarian donations in decreasing preventable mortality from cancer in low-income countries, models to improve access to life-saving medicines. And we're working closely with Pat and others to make many of the other life-saving medicines available to our patients. It takes a lot of people to do this. This is our cancer team in one of my recent visits to Rwanda. It's a great team. They're highly skilled at this point, and it's a privilege for me to be associated with them. They're the ones that do the heavy lifting. We try to support them in the care that they provide. And I wanted to end with this slide. On the left is Dr. Fidel, who at the time that we took this picture was one of our pediatricians taking care of this adorable little boy. And on the right at the time was the Minister of Health, Agnes Binawahu. She's now stepped down from that job, and she's the Vice Chancellor for the University of Global Health Equity, a new university across the valley from our cancer center. And Dr. Agnes said, linking humility and bold vision to scientific rigor is the surest route to value and equity in global health. And I would say that those words apply not only to Rwanda, but to the US as well. And training the next generation of oncologists is important in Rwanda and equally important in the US. And we were actually able to raise funds to send Fidel to Tanzania for an oncology fellowship. And just about a year ago, he graduated from his fellowship and is now in Rwanda, back in Rwanda as a practicing oncologist. And it's just been a huge benefit to our programs and obviously most of all to our patients. So I wanted to once again thank ACCC and Dr. Oyer for bestowing this award on me. I am truly humbled by it. It's you who are doing so much critical work in the US, and we're all thankful for that and grateful that you're going to continue that work.